let's pick that point up then, as you were saying. You're going to talk to us a bit about the immunosenescence and what is then the impact. Do you want to do it from here, or do you want to stand up?
Well, yeah, let me stand up. And,
so why is it then that the efficacy of these vaccines in older adults is so low? Why is that?
Yeah, so I mean, the answer is an easy answer, but it's also a complex answer. So it's due to immunosenescence. What happens as we get old, then our immune system starts to deteriorate, and because of that, then the response that we have against infection is not as robust as it used to be when we were younger, and then that's one of the reasons why influenza causes more complications in the elderly, because the immune system is not as good as it used to be. On top of that now, if we need to vaccinate to prevent severe disease in the elderly because they have not such a good immune system, the vaccine also is not going to induce a very good immune response, or at least not as good as in people that are younger. And then what it needs to be done is to improve vaccine immunogenicity. I think this is important in almost any group for influenza vaccines, but it's more high priority in the elderly because of the risk of serious outcomes. Now, I say it's simple, it's immunosenescence, but it's actually immunosenescence is a very complicated area of research, and it's due to multiple factors. So we have defects from the innate immune cells, the ones that are the first responders to virus infection, monocytes, NK cells, neutrophils, and also the first responders, antigen-presenting cells to vaccines, that they need to be activated for the vaccine to be immunogenic. In addition, we have exhausted memory T cells. The T cells, there is a lot of population of T cells that have been exhausted, and they are very difficult to reactivate. The naive T cell repertoire is also decreasing with age, so there is less repertoire, there is less antigens and epitopes they can respond to. We get decrease also in CD8s, the cells that are actually eliminating virus-infected cells. There is decrease in the HELP. There is less CD4 cells per CD8, so the CD8s don't get activated very well. There is also known that there is decreased telomerase with age, and that results in also less proliferation of T cells when they are needed to either respond to vaccines or for making help to the B cells or to respond to viral infection. So at the end, what we have in the elderly is a decreased response not only to flu vaccine, but to all vaccines. But there are not so many vaccines that have been used in the elderly, and the one that is used yearly is the annual seasonal flu vaccine. Now, this illustrates a little bit more from the point of view of the cells that are involved in combating viral infection. During flu infection, we can see that when the virus comes, it encounters antigen macrophages and antigen-presenting cells that become activated. Due to that, there is cytokines that are being released. There is monocytes that come, NK cells that come, the first innate immune cells that are taking care of the first replication of the virus. But as infection progresses, these dendritic cells also move to the lymph nodes. They activate T cells and B cells that come now with a specificity against influenza virus-infected cells, as well as making antibodies that will protect also against future infection. And all of these compartments are being decreased. All of these cells, they are not as functional in the elderly. So we have problems in all this type of cells. So what are the factors that influence then the influenza vaccine effectiveness? So that was during viral infection, but we have the same problems during vaccination. There is a reduced immune response to the vaccine in the elderly, and not only that, but the induction of cross-reactive antibodies versus mismatched strains is also reduced. That is also a problem in the case that there is a drift virus that is not completely matched to the vaccine. At the end, what we get is limited protection, as we have heard from George, offered by standard influenza vaccines. And what is required then in the elderly is vaccines with enhanced immune response that overcome immunosenescence, and that will result in improved clinical outcomes against influenza. So, again, what is the effect of immunosenescence? To summarize, first of all, there is, in terms of flu infection, there are more serious outcomes. 90% of the deaths in older adults are due to influenza deaths. 90% are in older adults. 3 and 4 hospitalizations due to influenza in the elderly, they result in death. And in addition, there is decreased response to vaccination. So the efficacy, we heard, is about 60% in healthy adults, but it goes to 27 to 40% in older adults. Now, having in mind that the efficacy is not as good as it is, what will be the effect of increasing the vaccine effectiveness in the elderly? And this is a study from our colleagues at the CDC that is not published, in which you can see in different seasons what will be the effect of having less hospitalizations due to influenza infection if you just increase a little bit, 5%, 10% vaccine effectiveness in this population. And especially it's more dramatic. You can see that it's improving and there is less hospitalization. It's more dramatic in years where the vaccine is not working to start very well due to mismatch, like it was happening in 2014-15. So little increases in vaccine efficacy would result in less hospitalizations, and certainly there is room for improvement with the existing vaccines. So what is the actual need in the elderly? First of all, in terms of the immune response, influenza vaccines are less effective in older adults due to decline in the immune system. The breadth of protection, they don't induce as effective breadth of protection against drifted strain in the vaccines, the traditional vaccines in the elderly. The immunity also wanes very quickly, which makes it very difficult to catch up this population at the time that they get protection, and then the virus comes. It can go away in just 4 months, even if there is a good response. And obviously the disease burden that is associated with the elderly is much, much bigger.